Hello, I'm Lisa Ballard. I'm a Senior Research Fellow from the Clinical Ethics and Law Research Group at the Uni of Southampton. I'm going to talk to you about a project we developed to explore public views of using routinely collected health data for learning in secondary care. The original methods we used did not generate the data we had hoped, so this presentation is to draw your attention to why the methods didn't work, the lessons we learned, and how we've moved forward. So firstly, let me give you a bit of background to our project. One of the National Health Service's guiding principles, among others, is to aspire to the highest standards of excellence regarding the quality of healthcare. However, one of the barriers to improvement is the separation of research and healthcare. Therefore, improvements often stall when viewed as purely research. Technological developments in healthcare data collection is one way to inhabit the hybrid space between healthcare and research. However, this type of development generates concerns about privacy, consent, and data protection. While such concerns are understandable, too much emphasis on these values comes at the cost of healthcare progress. Research focuses very heavily on asking individuals for consent to use their data in specific ways, but this is not always possible in practice, and underserved groups are often not represented in research for many reasons. Consent is important, but not all concerns can be addressed through individual consent, and the current process puts most of the burden on the individual to judge based on lengthy documents. For example, it could be useful to learn from data collected before a patient is admitted to a particular department, such as intensive care. But when these patients first enter the hospital, health professionals would not have known how that patient's care might progress, so would not have asked for consent to learn from the data before their admission into intensive care. So our aim was to explore stakeholder views regarding their health data being routinely available for research and learning purposes, and we wanted to start to work towards creating a better and trustworthy system for learning and innovation that benefits everyone. We used a rapid qualitative research design and conducted online focus groups in the summer of 2020. We recruited 29 participants, 21 of those were women, between the ages of 19 and 77. There were 6 focus groups in total, and we transcribed and analysed the transcripts thematically. So what went wrong? Despite our team's experience deliberating extensively regarding the content of the topic guides, and with several iterations of the guide after each focus group, the data was still unable to meet our research aim. Participants often had strong, polarised views regarding privacy and security that prevented nuanced discussion, and data saturation was quickly reached. So, for example, one participant, well, many participants were apprehensive, and this one says, I mean, if we're talking about a hospital, I'm not really sure, but for a GP, they have your weight, age, height, smoker, ex-smoker, alcohol use, previous prescriptions, EEGs, ECGs, anything you might have had that's also on record. Whether that translates over to a hospital setting, I'm not sure. And I don't know I'd want all of that information accessible to anyone in the NHS. And someone with an opposite view said, I have no concerns about the safety of my data in a healthcare setting, and researchers should be able to access our routinely collected data. So why did it go wrong? One reason might have been that there wasn't enough time for the science communication. Participants did not know about the problem or issue we were trying to resolve, and they weren't even sure what hospital data was. As the first quote mentions, they're not sure whether the hospital data is the same as GP data. Secondly, there wasn't enough time for deliberation, so it was only by the end of the focus groups and people had expressed their immediate reactions did we start to get some more nuanced data as people started to get to grips with the issue. It's a complex topic. We may have only recruited people who thought they had something to say and maybe essentially scared off anyone else that didn't know about the topic. And I must admit, as a researcher, I feel the topic is very complex, and that's why we've struggled to communicate the issue. And then the issue of the online focus group, we quickly learned that bigger groups didn't work, smaller groups were better. It was hard to facilitate when 1 or 2 people dominated the discussion, and it was really hard to pick up on cues when people wanted to speak if they were more hesitant about speaking up. And the other issue was our sample just wasn't diverse, apart from getting a great range of ages. And that has issues for health data poverty. So if we want to address issues of health data poverty, we have to be seeking the views of those underserved groups. Our sample was 72% women, so we need to reflect on that and why we didn't recruit more men. And why did it go wrong? Partly it might have been our methodology. We recruited via a snowballing method. We did have like social media posts, but mainly our participants were recruited through us recruiting friends and family and then asking them to recruit people. So we kind of just got more of the same people. It was online, so there might have been people that don't have access to the internet or share a device or even don't have a device to do something like a Zoom call on. And again, the topic was complex and the focus group method might have been intimidating. If you don't know anything about the topic and you have to talk in front of others and researchers, I imagine that is very intimidating. But it wasn't all bad. We did manage to generate some data around the attitudes to the use of data during a pandemic. So our focus groups up front concentrated on more general views about the use of data. But when we then started to talk about what would you think around your data being used to get us out of the pandemic, even people with really apprehensive views were willing to put aside concerns of privacy and security for the greater good, but were clear that they wouldn't want that to continue after the pandemic. And also we got lots of data around people speaking for others. So for example, this quote, "If it was for research, I'd tell researchers everything, but I know other people would think differently." We had instances of this throughout our focus group. So people saying, "I think this, but I think other people would think this." And it's something I've also observed in other data collection. So when I've been looking at familial communication of genetic test results, people do that as well. And I'd be really interested to know why people do that. What does it mean? Are they talking about their own views really? I don't know, and would love to know a bit more about that. So possible solutions. We don't think focus groups are an effective method to explore complicated topics such as this, especially when participants have limited previous experience. Therefore, we've developed this new approach, which includes these possible solutions. We are going to use offline methods, so we're going to use like a hard copy of a workbook, and we feel that this will maybe tackle some of the issues of access to technology. So if people have got a hard copy in front of them, they don't need to have anything else other than that material. We really want to get a more diverse sample, so we want to target underserved groups. We've got quite good data in the city of Southampton around health inequalities and particular areas of deprivation in the city, so we could do targeted posting of our workbook. And then we'd be collecting the views of people where that health data poverty actually might affect. We would have more time to do the science communication element. So the illustrations that you're seeing in my slides are actually been designed by an animator who's made an animation for us, which is actually communicating the issues that I've outlined in this presentation. And we are going to ask her to make a comic of that. So it's a hard copy. You don't need to go watch a YouTube video. And then hopefully that will give people time to kind of learn and understand that in their own time, get the background information, and then have time to kind of formulate their own views. We're going to do a story completion methodology. So that basically is where we write out a stem and we get the participant to finish what happens next, so we could get more nuanced views. And we're going to use the data from the focus groups from last summer to construct characters. So we're not discarding that data. It's useful and we can use it to construct those common views up front about privacy and security. So hopefully our participants will give us more nuanced views. Thank you very much for listening to my presentation.